then do it.
We are live.
Okay. Dr.
So,
Samir, start.
Yes. So, good evening, everyone. I, as a secretary, Dr. Samir, welcome you all to this World Glaucoma Week, and I'd like to welcome you all committee for taking so much pain. Thank you, everyone.
Amit, tomorrow kotiyala sabu. Voice.
Good evening, everyone. Am I audible, sir?
Yes.
So, I, on behalf of Odisha State Ophthalmic Society, of this World Glaucoma Week webinar, and I'd like to request Dr. Simon Star to start the meeting, sir. Thank you.
Dear friends, this is a webinar conducted by our scientific committee. They are regularly exploring to present new scientific topic to the Odisha State Ophthalmic Society. Now, in the World Glaucoma Week, they are conducting a webinar on the glaucoma. We have to see what they are kept for us in this webinar. I also welcome the AIOS members, Dr. Devashish and Dr. Mona, to be present, and they are spending their valuable time for the webinar. And I over to Scientific Committee Chairman, Sir Mr. Vera.
Thank you, sir. I welcome each one of you here. Dr. Devashish Chakrabarti, Dr. Mona, and Dr. Rita Das ma'am. We have a set of 8 case reports which will be presented by residents, faculty, as well as fellows. Those will be marked as per the score sheet that is shared. And at the end of the talk, after the discussions is over, we will declare the winners 1, 2, and 3. And let us take it as a huge learning curve, and let us discuss glaucoma, day-to-day glaucoma. Over to the moderator of today's session, Dr. Pranamita Pujari.
Thank you, ma'am. Good evening, everyone. So I would like to introduce our judges. We have Dr. Devashish Chakrabarti. He is a senior consultant in glaucoma and cataract at Center of Sight, Kolkata, and he is presently our East Zone executive member of our Glaucoma Society of India. And we have Dr. Mona Khurana. She is a senior consultant in glaucoma at Sankanetralaya, Chennai. She is my teacher also during my fellowship day, and she has a strong interest in all sort of academics and publication also. And we have our own Dr. Rita Das ma'am. She is a consultant at Manipal Hospital, Bhubaneswar. And like ma'am said, we have 8 presenters, and each presenter will get 4 minutes to present the case, and please stick to the time. We have shared the score sheet with the judges, and I welcome you all and all the best to all the presenters. Like ma'am said, take it as a learning experience, and all the 3 judges, I know they are the most soft-spoken person I know. MK ma'am and Devashish sir and Rita ma'am. So don't take tension and be free and present it nicely. All the best to everyone. First presenter is Dr. Lipsa Sahu. You can start sharing your screen. Dr. Lipsa.
Please mark the time, Dr. Pranamita. Please mark the time.
Yes, ma'am. Yes, ma'am.
Good evening, everyone. I hope I'm audible.
Yeah.
Sure. Should I start now?
Yes,
Yes.
you can start now.
Okay, I'm Lipsa. I'm a fellow at Glaucoma Services at LV Prasad Eye Institute, Bhubaneswar at MTC campus. So today I'll be presenting a case titled Breaking the Ice, Decoding the Management of Eye Syndrome. So coming to my case details, a 22-year-old female presented to our OPD with a chief complaint of gradual diminution of vision in her left eye since the last 1 year. which was associated with mild redness and pain. There was a history of past consultation 6 months back where a baseline IOP was recorded as 15 and 60 in right and left eye respectively. She was treated with IV mannitol and was started on 2 anti-glaucoma medications. So at presentation, the vision in her left eye was 20/80 paths, which was correcting up to 20/40. There was mild conjunctival congestion. Anterior chamber was shallow with 360-degree pass. The pupil was round, mid-dilated, and sluggishly reacting to light. Intraocular pressure was measured to be 46 mm of mercury under 2 AGM cover. Fundus revealed large size disc with near total cupping. On right eye examination, the anterior segment was unremarkable and the fundus showed 0.4 cuppus to disc ratio with a healthy neuroretinal rim. Gonioscopy revealed closed angles in the left eye and open in the right eye. The visual field showed severe glaucomatous visual field damage with a mean deviation worse than 22 decibels, correlating with the advanced disc damage. Specular microscopy showed decreased endothelial cell count, indicating endothelial compromise. So with this, our patient was diagnosed with left eye glaucoma secondary to eye syndrome. So to start the treatment, the AGMs were augmented. The patient was treated on a fixed dose combination of brinzolamide, brimonidine, timolol, and PGA analog travoprost, along with a BD dosing of Dimox. But at 2 weeks follow-up, her IOP still remained high at 48 mm of mercury, and hence the patient was planned for a left eye Ahmed clear plant glaucoma drainage implant. The surgery was uneventful. Ahmed clear plant implant, which is a non-valved glaucoma drainage device, it was implanted in the sulcus. At post-op day 1, her IOP was 40, the AC was deep, and the implant was in place. So AGMs were continued along with steroids and antibiotics. At post-op day 1 week and at 1 month, the IOP was again 24 and 30 as seen in the non-valved implants. So at 6 weeks, her IOP reduced to 7 mm of mercury. So here the AGMs were stopped and the steroids were gradually tapered. So essentially the management of eye syndrome, it starts with the use of topical aqueous suppressants, and surgery is mandated when the IOP is not controlled by these topical drops. Trabeculectomy has shown less favorable outcome in cases of eyes, especially due to formation of a membrane which blocks the infiltration site. Glaucoma drainage devices, especially the valveless implants in sulcus, have shown a better survival in eyes cases. Thank you.
I would request our judges to ask questions. Over to MK ma'am. I would request all the judges to limit their question 1 to each participant so that we'll conclude in time. MK ma'am?
Yeah, so interesting case. And I would like to ask when you see in unilateral glaucoma with such kind of features, what would be the differential which would come to your mind?
Actually, this case, ma'am, since the first, when I saw it, the first presentation, I thought it was some viral infection, the way she was presenting like photophobia and everything. And I actually misdiagnosed it as viral. And then when I showed my consultant, it is a classical presentation of eyes, where it also has an overlap component of viral as with the eye syndrome. And she has been on treatment for viral for quite a few times.
Yeah.
Whereas if I think of the other unilateral glaucoma, but not such, maybe a pseudoexfoliation glaucoma, but not features of involving the cornea, that will be my differential diagnosis.
Yeah, that's an interesting point you brought up. Many times we also do see patients with eyes who come on Acivir and antivirals because of the corneal and the iris involvement. So, what is a typical iris feature here which you could help, like, which would help you clinch the diagnosis here? And just for the benefit of others, you would like to point it out. I'm sure you saw it.
There was iris atrophy holes, the essential feature in progressive iris atrophy, the stretch holes, the melt holes.
Holes and nodules also you would see. I don't know if you
Yeah.
saw this case. Yeah.
This case wasn't there, but we've seen other cases
Yeah.
with nodules and mammaliations.
Yeah. So that's an important point here. Should I ask one more or should I pass it on?
Pass on, ma'am. I'll request Dr.
Okay.
Chakravarti to
Sure.
Yeah, thank you, ma'am.
Lipsa, we cannot see you. Okay, now we can see.
Yeah. Yes, over to Dr. Chakravarti.
Nice presentation, Dr. Lipsha. I just wanted to know, were there any special precautions you took during the surgery? Because this is a non-verb implant.
Yeah.
So what precautions you took while performing this Ahmed Clear Path? And what are the additional steps that you need to do in case of any non-verb implant or a part implant?
For specifically this case, we wanted a longer implant. We place it in sulcus, and the tube should be longer than what is normally done. The distal tube was cut longer than what is normally done, and also the insertion, it should be in the ciliary sulcus, not touch the corneal endothelium. Hello, am I audible?
Yeah, you are
Yes,
audible.
yes, please continue.
Yeah, so this case was mainly, it was a longer tube.
So anything else? How do you manage the hypotony? If it's a non-verb implant, patient will get a certain
Yeah,
hypotony.
already Ahmed Clear Plant has ripcord. So it has a pre-planned ripcord, which was there. So it will prevent hypotony. Mostly the cases do not require a ripcord removal.
So that was not visible in the picture you showed.
Yeah, it was they actually, we made another site, a scleral pocket where it was inserted. So it was not visible in that picture.
Okay. And you gave some venting slits also?
No venting slits was given in this case.
Okay. You removed the ripcord later on?
Yeah. This is actually a post of 2 months. 2 months. So we haven't.
So you yourself did the surgery?
No, it's my consultant. We have just started
Right.
implants.
Right. Okay. Thank you so much.
Thank you.
So over to Rita, madam. Rita, are you there?
Yeah, I am from my mobile.
Yes,
Am
ma'am,
I
you are
audible?
audible. Yes, ma'am, you are audible.
Yeah. Dear Lipsa, can you tell me the tricept you have given pre-op before surgery? What is the concentration of the drugs?
Brinzolamide brinzolamide is 1%,
Okay.
and brimonidine. Brimonidine, I'm not very sure, sir. I'm very not sure. Brimonidine, I'm not sure.
Madam, you should be very clear when you are opening, giving a drug, because brimonidine, it's available in 0.2%, 0.15%, 0.1%, because brimonidine, all of us know, causes redness and all those things. So a lot of changes are done. So before giving any medication, be careful. Huh? Thank you.
Yes, ma'am.
Ma'am has got you there, Lipsa, the basic of glaucoma.
Yes. I don't remember tricept concentration.
Yeah, okay. It's okay. Okay. Thank you, Lipsa. Our next, thank you, Lipsa. You can stop sharing your screen also. Yeah. So next participant is Dr. Nivedita Sahu. Nivedita, you can start sharing your screen.
I hope it is visible now.
Yeah, visible, but you have to make it like slideshow.
Yeah. Am I audible clearly?
Yes, you are audible. Yeah.
Okay.
You can start.
Okay, just a second. Yeah. So, good morning, esteemed judges, my teachers, colleagues, and dear friends. So, I'll be presenting today a very interesting case, the hidden dangers, drugs, and angle closure. So the objectives of my presentation in the next 4 minutes would be to know the mechanisms of drug-induced angle closure, the various class of drugs causing angle closure glaucoma, and the management. So what we know is the primary angle closure predominantly caused by relative pupillary block, and secondary angle closure can be broadly categorized by anterior pulling and posterior pushing mechanisms. So I present to you a 65-year-old man with wheelchair-bound patient from Odisha with chief complaints of sudden diminution of vision associated with pain and watering in both eyes for 1 week. And the uncorrected visual acuity was 21-25 in the right eye and counting fingers 2 meters in the left eye. In both the eyes, there was conjunctival congestion. There was microcystic corneal edema. The Van Herrick grading was grade 1, and the pupils were sluggishly reacting with nuclear sclerosis grade 1 in the right eye and grade 4 in the left eye. The intraocular pressure in the right eye was 32 millimeters of mercury, and in left eye it was 26. On gonioscopy, there was a position and angle closure in all quadrants. And as the fundus was easily seen, I just saw the past history of the patient. He was a known diabetic, which was controlled on medications since 10 years. There was a history of hospital admission for hemorrhagic stroke for 2 weeks, for which he was treated with IV mannitol, and he was on tablet acetazolamide, pregabalin, and pantoprazole. So as I was suspicious, I did a B scan of the right eye, and it was suggestive of bilateral annular serous choroidal detachment. And to confirm my high index of suspicion, which was already there, I did a UBM, and it clearly showed the anteriorly rotated ciliary body with ciliary body edema and the narrowing of the ciliary sulcus with supraciliary effusion, all quadrants. So I made a diagnosis of both eyes drug-induced secondary angle closure glaucoma with senile cataract, and concluded that the offending age is tablet acetazolamide, and we asked the patient to stop oral acetazolamide. Along with that, we prescribed topical prednisolone acetate steroid cycloplegics and 1 topical anti-glaucoma medications. So let us discuss about the mechanism of drug-induced secondary angle closure glaucoma. That could be due to pupillary block, which would commonly caused by the adrenergic drugs or serotonergic medications such as triptans and antidepressants, antipsychotics, which cause swelling of the crystalline lens and induce forward position of the lens iris diaphragm, and causes meiosis. And it could also be because of direct mechanical pressure, because of supraciliary effusion, which leads to forward rotation of the ciliary body. And it is seen in drugs like sulfa drugs, which causes idiosyncratic reaction. The topiramids and acetazolamide are the most common agents. And these drugs bind to the choroidal tissue and act like foreign antigen, causing an immune reaction. So both these mechanisms, they cause induced myopia and shallow anterior chamber. So let's see what happens in the next 1 week. The vision is improved. The intraocular pressure is under control. However, there is still shallowing of the anterior chamber. But the B scan has shown a resolution of the serous choroidal detachment. So this I took 0.3 and the
10
left.
seconds more only. Okay.
Sorry?
You can sum up the case.
Yeah, it is already done.
Yeah.
So in the next 1 month, the anterior chamber is deep now. And these are my take-home points. So the most important is to differentiate primary angle closure from secondary, and the demonstration of myopic shift in the secondary angle closure is very important. So I conclude with the drugs which are causing secondary angle closure. Thank you.
Okay. Thank you, Nivedita. Over to Dr. Chakravarti sir for questions.
Please unshare your slides.
Yeah.
Okay, nice presentation, Dr. Nivedita. So how do you differentiate such a case between whether it's a primary angle closure glaucoma or it's a drug-induced angle closure glaucoma? Because acetazolamide, acetazolamide is rarely indicated. It is there in the list, but there is always a suspicion whether that is the main etiology or not. So how do you clinically differentiate?
So there are 3 key points which differentiate primary from secondary angle closure. One is acute bilateral simultaneous involvement of both the eyes of angle closure. Second is annular 360-degree cilio-choroidal detachment on B scan. And third is a myopic shift in refraction. So these are the 3 points which differentiate a primary and a secondary angle closure glaucoma. And uveal effusion is also seen in primary angle closure glaucoma, but it doesn't go much posteriorly. So this, I think this answers your question.
What imaging did you advise for this patient?
I just did a B scan and a UVM.
Okay, you did an UVM. Right. Okay, thank you.
Yeah, Emeke ma'am, your question, please. Hello? Emeke ma'am, are you there?
Muted, yeah.
Yes.
So it was nicely managed and a good diagnosis. So suppose the angle did not, the AC did not deepen. Was there any procedure you could have done in this case? If it didn't work, then what? Any procedure could have been done?
Yeah, ma'am, actually, we can do a laser peripheral iridotomy. However, in this case, because it was acetazolamide and the cause is not primarily pupillary block, so laser PI is not indicated here. The cause here of secondary angle closure is uveal effusion, the ciliary or cilio-choroidal effusion, which has caused the secondary angle closure.
PI will not work, as you said, but any other laser may work. That's what I'm asking.
I haven't read in literature. I have not read in literature. I have read it extensively because I'm doing something in this, but like I haven't come across. Maybe you can enlighten me, ma'am.
So if it's not coming down, you can do a iridoplasty.
Okay.
In case the angle is not opening. That has a short-lived duration, but it may serve the purpose.
Okay. Thank you so much.
Okay. Thank you, ma'am. Rita ma'am, are you there?
Yeah. Dear Nivedita, actually, it's a conjunctival congestion or ciliary congestion.
It was, ma'am, diffuse conjunctival congestion. It was not exactly a circumciliary congestion.
It's a mixed type of congestion, most probably.
Yes, ma'am.
Because
It was a
when it's
diffuse conjunctival. It was intense conjunctival congestion, which was there. Slight chemosis, which is common. I did not tell it, but like slight chemosis was there.
Because if it's only conjunctival congestion, then we have to mention what type of discharge, anything like that. When you're telling it's microcystic edema and all those things, so conjunctival congestion for postgraduates, actually they have to very clear what to write. I think it's a mixed congestion. Paramita, would you like to add anything?
Yes, ma'am. Let's finish this at the end of this thing. When tabulation will be going on, we'll discuss in detail all this case if time permit.
Okay.
Okay, ma'am. Because when tabulation will go on, no, Samishta ma'am will tabulate. At that time, we can discuss all the cases.
Okay, thank you.
Okay, ma'am. Thank you, ma'am. So our next presenter is Dr. Devasis Biswai. Devasis, you are muted, Devasis.
Good evening to all of you.
Yeah.
Start sharing your slides.
Your screen.
May I start, ma'am?
No, your screen is not visible. You can go back once. Close it once and share again actually. It was visible before. When you made it slideshow, no, it's not visible. Yeah, it's visible now. You can start.
Ma'am, I'm not able to share my screen now.
No, it's visible.
Uh,
Your screen is visible. You can start.
Good evening to all of you. Seeing the impact, how trauma meets secondary glaucoma. There is no financial disclosure. Introduction. Blunt trauma to the eye results in sudden compressive deformation of the globe. It displaces the cornea and enters sclera posteriorly with compensatory expulsion of globe in equatorial direction. The following forms of the intersegment injury can be seen after blunt trauma to the eye. There can be radial tears, there can be iridodialysis, there can be cyclodialysis cleft, there can be trabecular meswork tears, there can be lens subluxation and dislocation, as well as there can be retinal detachment and dialysis. The aim of my case is to evaluate the visual outcome of subluxation of lens with secondary glaucoma. If female presented to our OPD complaining of photophobia, diminution of vision and redness in left eye following blunt trauma by punch of a child 12 days back. For which she sought treatment elsewhere but without any relief. There is no history of any previous trauma, surgery and similar family history. On exam 45 millimeter of mercury, the cornea was a pupillary block with mid-dilated pupil and the lens was inferonasal, anteriorly subluxated from 5 to 11 o'clock position. The right eye, on right eye examination, there was not any significant finding. The following picture depicts the slit lamp view of the left eye on diffuse illumination. An anterior segment OCT of the left eye was carried out, which confirmed my above findings. A B scan and the fundus image of the left eye shows that there is no posterior segment pathology. On ruling out these all differential diagnosis, the diagnosis of my case is a inferonasal subluxation of lens with secondary glaucoma of left eye following blunt trauma. The patient was started on medical management. After 2 days, the IOP reduced from 60 to 45 to 32 millimeter of mercury and visual acuity improved from 6/60 to 6/18. The cornea became clear. A gonioscopy was carried out which showed the anterior segment structures up to a Swalbase line were seen in the inferior and the medial quadrant. And the medical management was continued. A superior-temporal peripheral iridotomy was carried out in the same setting. After 2 days, on examination, the visual acuity improved from improved to 6/18 and the IOP was 30 millimeter of mercury. Then suction with exclusion positively the IOP reduced from 36/18 to 6/9 with pinhole on Snellen's chart. My take home message is never take blunt trauma to eye lightly. Early diagnosis and active intervention will give us good prognosis. Thank you. Hello? Hello?
Share. Please unshare.
Over to Rita ma'am for question. Rita ma'am?
Hello?
Yes ma'am, you are audible.
Yeah.
You are audible ma'am.
I'm audible.
Yes ma'am, you are audible.
Debasis? Hello?
Yes, ma'am. Yes,
Hello?
ma'am. Yes, ma'am.
Hello? Debasis?
Yes, ma'am.
No, I'm asking Debasis. Actually, how many days you have followed up this case? How many days you have
Ma'am,
followed up?
I have followed up this case. Ma'am, up to 1 month, ma'am. After surgery, we have followed it up to 1 month. And the patient
trauma.
lost to follow up after 1 month. After 1 month, ma'am.
Okay. After 1 month, he lost to follow up.
Yes, ma'am.
Okay. What are the actually what you have counseled before you have last seen the patient?
Excuse me, ma'am.
Because it's a case of blunt trauma. It's a case of blunt trauma.
Yes, ma'am.
How you have counseled the patient?
Ma'am, we
What
have
you have told?
Ma'am, we have counseled the patient about the poor prognosis because as it is a case of blunt trauma and the patient presented after 12 days of injury. The visual acuity was 6/60. So we have counseled her about the great visual prognosis after surgery, following surgery to her. Because
there is no suppose there is no lens subluxation or lens is no genular dialysis. Okay, in a blunt trauma.
Yes, ma'am.
What is the follow-up schedule? What you will tell to the patient? What you will tell to the patient? In a blunt trauma, suppose there is lens is not there is no genuine dialysis. There is no subluxation or nothing wrong with the lens.
Ma'am, after following a blunt trauma, if had there been any hyphema, then we had after resolution of the hyphema, we have done a gonioscopy and seen the anterior angle structures. If there is any iridodialysis, if there is any cyclodialysis left, and if there is any angle recession, taking these things into account, we would counsel the patient.
What is angle recession?
Ma'am?
What is angle recession? What is angle recession? And tell me. And the second question is,
ma'am, following blunt trauma, when there is a split between the longitudinal and radial fibers of the ciliary body band, the gap is created.
Is there any risk to the second eye? Is there any risk to the second eye for glaucoma point of view?
Yes, ma'am. It is seen that following the blunt trauma, in cases of blunt trauma to one eye, there can be compensatory increase in the pressure. We're also seen in the eye, contralateral eye.
Thank you.
Compensatory. Okay.
Thank you, ma'am, and thank you, Devasis. I think enough question for you. With that, we'll go to the next presenter, Dr. Smruti Mishra. Smruti, please start sharing your screen.
Yes.
Make it full screen. Yes.
So, a very good evening to everyone present here. Am I audible now? Is my voice okay?
Little low it is. You can speak little louder.
Okay, ma'am. Is this okay now?
Yeah, yes, okay. You can start.
Okay, ma'am. I'll be presenting an interesting case. The devil is in the details. So coming to my case details, informed patient consent was taken. There were no financial disclosures, no conflicts of interest. Coming to my case, this patient was a 21-year-old female with complaints of headache, vomiting, and generalized weakness since 3 weeks. She had history of chronic headache and was on migraine prophylaxis with tablet topiramate with recent dose increment from 25 milligram to 50 milligram once daily. The patient recently had a change of glasses about 2 months back. She earlier had a refractive error of -2.5 diopter spherical in the right eye and -2.25 diopter spherical in the left eye. but upon this visit, her myopia had worsened. It had come to -5 diopter spherical in the right eye and -4.5 diopter spherical in the left eye. Coming to the general and systemic examination, it was within normal limits with pulse rate about 88 beats per minute, regular, and blood pressure was 128 by 82 millimeter mercury. Coming to the ocular examination, this patient had a best corrected visual acuity of 6/6 in both eyes with normal near vision and normal color vision in both eyes. Upon slit lamp examination, there was diffuse conjunctival congestion with shallow anterior chamber depth in both eyes with minimal cells and flares. Upon gonioscopy, there was an occludable narrow angle in both eyes with Von Herrick grade 1. Extraocular muscle movements were full, free, and painless in all directions. Intraocular pressure upon NCT was 25 millimeter of mercury at about 12:15 p.m. and fundus photography showed grade 4 papilledema in both eyes. Coming to the OCT of optic nerve head, it showed increased bilateral RNFL thickness with disc swelling in both eyes. We did a Humphrey visual field analyzer perimetry with theta standard 30-2 technique. It showed large and enlarged blind spots in both eyes. B scan, the B scan showed marked choroidal thickening, and the NCCT brain which was done showed no signs of any intracranial space occupying lesions. So coming to my differential, what could it be? Could it be acute anterior uveitis, or but the AC reaction seems fairly minimal. Could it be a case of idiopathic intracranial hypertension? Maybe, but an LP is needed to confirm. Could it be a case of hypertensive retinopathy grade 4? The patient was too young for this diagnosis and her blood pressure at the time of OPD visit was within normal limits. Or could it be a case of AION? But the vision in this case was fairly good. So what else could it be? Could it be a case of acute angle closure attack? The patient had a mild AC reaction, a shallow anterior chamber, and the IOP was on the higher side. So to further investigate, we did an ultrasound biomicroscopy to visualize the angle structures. It showed ciliochoroidal effusion with anterior translation of the ciliary body and shifting of the lens iris diaphragm, causing angle closure glaucoma. So why the ciliochoroidal effusion? Topiramate is a sulfur group drug which is used for the treatment of epilepsy and migraine prophylaxis. It can cause anterior rotation of the ciliary body or with or without choroidal effusion, resulting in shallow anterior chamber. It can result in acute onset of myopia due to anterior shift of lens iris diaphragm, and hence resulting in severe headaches, eye ache, myalgia, nausea, and other symptoms. So we did a literature search and we found quite a few studies supporting our claims. So acute bilateral secondary angle closure glaucoma has been frequently reported as a side effect of many medications, most often topiramate. Another study showed that both bupropion and topiramate, which are widely prescribed drugs, they have a high propensity to cause angle closure glaucoma, acute angle closure glaucoma. So considering the recent initiation of topiramate in this patient with dose increment shortly after, supported by literature search and no other precipitating events, we diagnosed this to be a case of drug-induced secondary angle closure glaucoma due to topiramate. So how did we manage this case? The patient was advised to stop topiramate after obtaining neurologist opinion. We started the patient on brimonidine tartrate 0.2% with timolol maleate 0.5% eye drop twice daily, homatropin eye drop for cycloplegia, and prednisolone acetate 1% eye drop, 1 drop 6 times per day with tapering, along with tablet prednisolone 60 milligram OD with tapering. After 8 weeks of follow-up, the disc edema had disappeared with regain of normal visual field, no residual myopia, or as in the myopia had come down to her previous refractive error, and there was no evidence of any papilledema or raised IOP. So my take-home message is that the devil is in the details. History taking and literature search are of paramount importance in clinical practice, and patients being prescribed such medications must be counseled about the risk of rise in IOP and must be encouraged for regular follow-up visits. Thank you.
Thank you, Smriti. Another drug-induced case, apparently drug-induced or something mixed is going on. We'll see. So over to MK ma'am for questions.
Yeah, so I think you talked about the literature search. So let me ask first regarding that. Did you find any case with the disc edema like this and topiramate-induced secondary angle closure. Did you find any case in literature regarding that? That is one thing. And secondly, when you see a disc like that, can you hear me? Am I?
Yeah, you are audible, ma'am.
Okay. So when you see a disc like that, I mean, attributing it to topiramate is actually a diagnosis of exclusion. So you did exclude some things, but some things still need to be excluded. Did you do a CSF opening?
No, ma'am, we did not do an lumbar puncture because we thought since topiramate could be an inciting agent, so instead of going for an invasive procedure first, we should try with something more benign.
And were there any vitreous cells, like any one condition which also could present like this, which you have not mentioned here? Any kind of inflammation? You already said anterior segment, but any other kind of inflammation? That's a hint.
Or posterior uveitis, ma'am.
Which one?
Ma'am, VKH or VKH.
Yeah, that should rule out that.
Thank you, ma'am. And over to Devashish sir for questions.
Yes, I think Madam just picked up the important points. So you should rule out VKH in such a case because finding papilledema in a case of drug-induced topiramate, drug-induced angle closure with topiramate is very unusual. In fact, topiramate is given as a treatment for papilledema, like acetazolamide. So that is unusual in this case. Yeah. Anyway, well presented.
Okay, our next presenter is Dr. J. Dakhini. Dr. J. Yeah, you can start.
Am I audible?
Yeah, you are audible. You can start.
One second.
Yeah, you are audible.
Yeah,
you can start.
Not able to change the slide.
Slideshow is not going on. Yeah, it's running. Your slides are moving.
Yes, my patient, 54-year-old male, clerk by occupation, came to Rubia Hospital with chief complaints of diminution of vision in both eyes for the last 2 years. The diminution of vision in both eyes, which was insidious in onset, gradual, painless, and progressive in nature, associated with intermittent watering from eye and headache. Headache is not associated with nausea and vomiting. Frequent change of glasses within 2 years was also complained by the patient. There is no history of trauma to the eye, nausea, vomiting, sudden transient visual loss, metamorphopsia, colored halos or floaters. History of past illness, no significant past surgical history, no significant past ocular disease of similar complaint was found in the patient. Medical history, patient is diagnosed as a hypertensive and is on treatment for 5 years. No history of diabetes mellitus, asthma, migraine, hyperlipidemia, or cardiovascular disease. Drug history, patient is under antihypertensive medications. No history of steroid use in any formulations. No history of topiramate and TCA use. No other significant drug history. No known drug allergy. Personal history, patient addiction of cigarette smoking for 6 years has been reported. No significant family history. General examination, patient's blood pressure was 158 by 90 millimeters of mercury. Pulse rate was 94 beats per minute. On ocular examination, in both eyes, unaided distant vision was 6 by 60, which improved to 624. Near vision was N80. Color vision in both eyes was within normal limits. Pupillary reflex was brisk. Ocular motility full in all gazes. Eyeball was in orthophoria. Eyelids and conjunctiva, both eyes normal. Conjunctiva normal. Cornea clear. Anterior chamber depth was normal. No cells or flare. Iris was normal. Slit lamp examination. Pupil was round, regular, reactive to light. No RAPD was present. No exfoliative materials were seen or pigments present at the pupillary border. No posterior synechiae present. Pupillary rough was normal in both eyes. Coming to the lens, in both eyes, NS1 cataract was seen. No pigment/exfoliative material deposition was there. No phacodonesis. On gonioscopy, wide open wide open in all angles. Iris insertion was flat, no angle recession, dusty pigmentation of the angle, no peripheral anterior synecdoche, and neovascularization seen in both eyes, no pigmentation on the Schwalbe's line, no surgical or laser ostium was seen. Optic disc vertically in the right eye, vertically oval disc with vertical cup to disc ratio of 0.6:1 ratio. No disc hemorrhage present at present. In the left eye, vertically oval disc with a cup disc ratio of 0.7 to 1 was seen. No disc hemorrhage was present. A disc color pallor of the disc was present more in the left eye as compared to the right eye. Neuroretinal rim showed superior rim notching in the right eye and superior as well as inferior rim notching in the left eye. Blood vessels in the right eye and left eye, nasal shifting was present. Peripapillary alpha and beta zone were present in both eyes. Macula normal foveal reflex was seen. And this is the optic disc of the right eye and the left eye. Intraocular pressure on applanation tonometry, right eye was 24 millimeters of mercury and the left eye was 26 millimeters of mercury. Visual field analysis done on the Humphrey field analyzer 24-2 protocol was used. It showed both eyes superior and inferior arcuate scotoma was seen as seen in this, and it followed the Anderson's criteria. So my provisional diagnosis in this case is an open angle glaucoma. Treatment: patient was advised consultation after 1 week as we cannot diagnose POAG in one visit. Patient was started on latanoprost on subsequent visit, 0.005% eye drops once daily. Patient was advised to follow up after 1 month. On following visit, on applanation tonometry, pressure in both eyes was 22 millimeters of mercury. Patient was started on timolol eye drops 2 times a day. Patient was asked to continue the same drug, that is latanoprost.
Your time is over, Jay. Please sum up.
Okay. The following visit, after 1 month, the IOP on applanation tonometry was 18 millimeters of mercury, and the patient then did not follow up. Thank you.
Thank you, Jay. That's an honest presentation. Like you said, we cannot diagnose the case in 1 week, so we call the patient after 1 week. Over to Rita ma'am for questions.
Hello, Dr. Jay. Actually, am I audible?
Yes, ma'am.
Yes, ma'am, you are audible.
Yeah. Your best corrected vision, you told it's 624 in both the eyes.
Yes, madam.
But you told your macula is foveal reflex is normal.
Yes. Yes, madam.
And pupil reaction is normal. It's
Yes,
round, normal in size, round, regular, brisk reaction to light. And
Yes, ma'am.
optic disc, you told there is pallor.
Yes, madam.
But in the picture, leave it. But why the vision is best corrected vision is 624? What's the cause?
Ma'am, it is probably due to the associated cataract that is present in this patient, which
You told
due
it's
to
a nuclear sclerosis grade 1.
yes, madam. That's why it in the
Nuclear
patient that
sclerosis, in the nuclear sclerosis grade 1 doesn't account for this vision loss.
ma'am, his vertical cup disc ratio 0.6 and there was pallor associated. So all these factors must have contributed to his loss of vision, which could not be corrected with
But
best
what
correct.
you showed in the visual field, that might be because of that learning effect.
Yes.
This is the first field. The
Yes,
first
madam.
field of the patient, first visual field.
Yes, madam. This is the first visual field of the patient.
But it is not. But pallor, I can't tell because it's a two-dimensional picture.
Yes.
We are seeing, but that optic disc is not matching with your visual field. So have you repeated that visual field?
Yes, madam. Any case of glaucoma, I have to repeat the visual field on 2 occasions. So on the subsequent visit, when I ordered for follow-up on the 2nd month, so when he came to me, I had ordered a perimetry was done, and same features were found, and no progression was seen in this case, madam.
Same field. It was consistent.
Yes, madam. It was consistent after 1 month.
Okay. Thank you, ma'am. We'll move to the next. Amika ma'am, you have any question for him?
Just a small question, Pranamita.
Yes,
Why Jai Dakshini has WI's virtual background?
Yes.
From the last meeting, it has been like that. So because I'm not in my room, I'm outside actually. So I thought I'm on duty. So
Just on a jovial note, okay?
Good.
I know, madam, but I couldn't find
Women's
the
Day
World Glaucoma Day
celebration.
thing.
Women's
I know about the background, madam. So I was on duty, so I thought I'll just present
You
without
won't get
background.
extra marks for that. Hmm. So since
Thank
the
you so much.
structure and function were not correlating, was anything else you could have done to, check that? Any other test you could have done?
So,
My favorite
madam,
test, actually.
so actually, I was suspecting the vision loss to be due to cataract. So I did this pinhole vision, with which the patient was improving to 6/6 parts. So maybe his disc pallor, disc ratio, as well as his cataract has contributed to his best corrected visual acuity being 6/18 in both eyes.
So, I mean, the
Also
disc and the
associated
field not
perimetry,
correlating.
and the perimetry also showed some significant findings. So that is why.
But it was not correlating to the other structural you would have done to check that. Because sometimes the learning curve takes not more than 2 fields.
Thank you, ma'am, and thank you, Jay. Our next presenter is
Glaucoma progression analysis on the perimetry is also one function in which we can actually assess the patient on subsequent visit, and it gives us a progression. So maybe I can go back and look into that, and maybe next meeting I can share that.
Jay will come back to you at the end of this competition. We'll discuss and we'll let you know also where do you like fail. Okay. Our next presenter is Dr. Pragya Bharati Nanda.
Yes, ma'am.
Yeah, your visual. Share your screen.
One second.
Ma'am, is my screen visible?
Yes, make it slideshow. Yes. Yeah, you can start.
Good evening, everyone. Myself, Dr. Pragya from Bhimsar Bulla, going to present a case of facultative glaucoma. The patient's consent has been taken, no conflicts of interest and no financial disclosure. So my patient of 50-year-old female patient presented with chief complaints of redness, watering, pain and diminution of vision in right eye since 15 days. The patient was a known case of hypertension and the patient was using tablet acetazolamide, eye drop gatifloxacin and prednisolone, eye drop timolol, tablet telmisartan, and the patient had history of cataract surgery in the left eye 1 year back. The patient developed redness, watering and pain in right eye, and she was initially treated with tablet acetazolamide, eye drop gatifloxacin with prednisolone and eye drop timolol at a local hospital, and the general systemic routine hemogram evaluation was within normal limit. The anterior segment examination of right eye showed decrease in interpalpebral fissure. There was conjunctival congestion and circumciliary congestion present. The cornea showed microcystic corneal bullae with diffuse stromal edema. In the anterior chamber, there was dense flare along with pseudo-hypopyon with chunks of whitish particles, and the lens was hypermature. The left eye, in the left eye, the anterior segment examination was within normal limit, and the lens was pseudophakic. The visual acuity of right eye was PL present and PR accurate, and in the left eye, it was 6/60. The intraocular pressure in the right eye was 60 millimeter of mercury, and in the left eye, it was 18 millimeter of mercury. The B scan of right eye was done because dilated fundoscopy could not be done, and it showed hyperechoic vitreous opacities. So my provisional diagnosis is right eye facultative glaucoma. The initial increased intraocular pressure was managed by giving injection mannitol 300 ml intravenously, injection pantoprazole, tablet acetazolamide 250 mg BD, eye drop timolol maleate 0.5%, 1 drop 2 times a day, eye drop gatifloxacin 0.3%, 1 drop 4 times a day, eye drop prednisolone acetate 1%, 1 drop 6 times a day, and the patient was planned for lens extraction along with intraocular lens implantation. The intraocular pressure post mannitol was 32 millimeter of mercury. And after adequate management of intraocular pressure, the lens extraction was done under local anesthesia. But jonular dialysis noted with disruption of posterior lens capsule. Peripheral iridectomy was done and the patient was left aphakic for a later scleral fixated IOL surgery. The patient was advised to use eye drop brimonidine and eye drop timolol 1 drop 2 times a day, eye drop gatifloxacin with prednisolone 1 drop 6 times a day to taper gradually, eye drop cyclopentolate 1 drop 3 times a day, tablet acetazolamide 250 mg BD and tablet pantoprazole 40 mg OD. The post-op intraocular pressure was 35 mm of mercury. This shows the post-op image of the patient after cataract extraction. This table summarizes some of the recent case reports of faculitic glaucoma, and the mainstay of treatment remains hypotonic treatment along with cataract extraction. So my take-home message is the consequences of delayed treatment can lead to irreversible optic nerve damage, permanent vision loss, and secondary complications can occur such as chronic inflammation and corneal decompensation. So the message here is early detection and timely intervention can prevent blindness. These are some of the awareness messages by eminent ophthalmologists, which emphasizes on preventive eye care and early screening, and where patient education is the key factor. Thank you.
Thank you, Pragya. You finished dot on time. Over to Devasi sir for questions.
Dr. Pragya, what was the patient's vision after the surgery and what was the intraocular pressure after you did the cataract surgery?
Sir, the visual acuity was around 5/60 after surgery, and the intraocular pressure was 35 mm of mercury post-op.
So how do you manage the patient now? Because the pressure is still high, he has some residual vision. How do you go about managing this patient now?
Sir, the patient is advised to use eye drop brimonidine along with eye drop timolol, and the patient was also taking tablet acetazolamide 250 mg.
Yes, but then the patient cannot take this for long, no, the tablet acetazolamide. Are you not planning surgery for this patient?
Sir, peripheral iridectomy has been done, and after scleral fixated IOL surgery, the patient can be planned up for any glaucoma surgery.
So in the case of faculitic glaucoma, it is said that if the duration is long, after a few weeks, maybe after a week or more, you can plan combined cataract and glaucoma surgery. Okay. So
Yes,
even now in this patient, the patient is aphakic, pressure is high. So you can think about a secondary IOL along with a trabeculectomy.
Yes, sir.
Thank you.
Thank you. Any question from Amika ma'am?
Yeah, so this is something related to it was a woman, right, who had, so generally both faculitic and phacomorphic, it has been reported more commonly in women. Why would you, any thoughts on that?
Ma'am, because
This is just to raise awareness.
ma'am, because in rural population, the women are usually neglected for cataract surgery in advanced cataract, and later they develop lens-induced glaucoma.
Yes, so socioeconomic status because of that. So usually it's the second eye. So most of the reports from India, they so it's just to what can you do to raise awareness? Can you do something to raise awareness regarding this?
Early screening for cataract and the regular follow-up for vision checkup can help the patients, and we can prevent glaucoma by doing cataract surgery in mature and hypermature cataract patients.
Okay. So basically, educate them to get
Yes,
this
ma'am.
other eye surgery done. Usually it's the other eye, right?
Yes, ma'am.
Okay, thank you, ma'am, and thank you, Pragya. Our next presenter is Dr. Soumyasri Samal. Soumyasri? Yeah, your slides are visible, but you have to make it slideshow. Yeah. You can start.
Good evening, everyone. I'm Dr. Soumyashri Samal, postgraduate from KIMS Bhubaneswar, is going to present an interesting case of facultative glaucoma.
So, Soumyashri, 1 second, I have a request. Please switch on your video. We are not able to see you. While presenting, at least your video should be on. Please switch on your video.
Okay.
Soumya, hello,
Yes,
Dr. Samal.
Yes.
Yeah.
Actually, the video thing.
It's okay.
Okay, you can start. Okay, the time is run. Okay, you can start anyway.
Dr. Sama, can you please make it in PowerPoint show mode?
Yes, sir. Good evening, everyone. I'm Dr. Soumyashri Samal, postgraduate from KIMS Bhubaneswar, is going to present an interesting case of facultative glaucoma. So my patient, 65-year-old female from Khordha, presented with diminution of vision in right eye since 2 years, which was associated with pain, redness, watering with progressive whitening of the right eye for the last 2 days. She consulted a local ophthalmologist and was diagnosed as right eye phthisis bulbi. There was no history of any head or ocular trauma or ocular surgery. She is a known case of type 2 diabetes, hypertension, hypothyroidism, and coronary artery disease, for which she underwent PTCM 7 years back. On examination of the left eye, her best corrected visual acuity was 6/36 and N24. Rest anterior segments were essentially within normal limit with the lens of nuclear sclerosis of grade 3. On examination of right eye, best corrected visual acuity was positive projection or perception of light and inaccurate projection of rays. There was mild lid edema, minimal conjunctival congestion was noted, diffuse stromal edema was present. Intraocular pressure using Goldman applanation tonometry of right eye was 40 mm of mercury and left eye was 16 mm of mercury at 12 noon. Gonioscopy of right eye was deferred and left eye angles were open in all the quadrants. As we cannot see the posterior segment of the right eye, we did a B scan of right eye, which showed anechoic vitreous cavity and attached chorioretinal complex. Left eye fundus was normal. So with the history and the clinical examination, we came to a provisional diagnosis of right eye lens-induced facultative glaucoma and left eye senile cataract. The patient was requested for admission and the nature of disease and visual prognosis was explained. Then she was given topical steroid, cycloplegic, topical anti-glaucoma and systemic anti-glaucoma medications. Next day follow-up, anterior segment findings were the same and intraocular pressure was still high. So she was taken off her right eye small incision cataract surgery under guarded visual prognosis. Post-operatively, patient was symptomatically better with right eye best corrected visual acuity of 6/36 and intraocular pressure of 10 mm of mercury. But the lens was slightly decentered inferiorly. So pathophysiology for facultative glaucoma, macrophage theory, where there is disruption of the lens capsule. So the high molecular weight lens protein are phagocytosed by the macrophages, and the macrophage latent phagocytosed lens protein obstruct the trabecular meshwork, which increase the IOP. There is another theory of soluble lens protein, which directly block the trabecular meshwork and increase the IOP. So my take-home message will be facultative glaucoma and other lens-induced glaucoma are ocular emergency. So goal of management medically is to relieve the symptom of pain and reduce the inflammation and intraocular pressure, and surgically we should do cataract extraction. It is important to counsel the patient about the permanent visual loss and to treat it as early as possible. As the disease has good prognosis in most cases, so the prognosis should be explained carefully to the patient. In this modern era of cataract surgery, we rarely see like this kind of clinical presentation of facultative glaucoma, as we have seen in these cases, as it is neglected one. So the purpose of this presentation is to create awareness about this type of presentation so that we don't lose a single eye due to glaucoma.
Yeah, please unshare.
Yes, ma'am.
Hello, Pranamita. Hello. You can ask the questions. Unmute.
Rita ma'am, are you there? Yes, ma'am. You can over to Rita ma'am for questions.
Yeah, so Messi, actually, it's a facolitic glaucoma.
Yes, ma'am.
Post-operatively, would you like to give cycloplegic or not? Just tell me.
Ma'am, cycloplegic we mainly give for the pain, this to relieve the ciliary spasm. So post-operatively, she was feeling better. There was no pain, and the pain was decreased. So,
Operatively, no cycloplegic.
yes, ma'am.
Because in the previous presentation also she told cyclopentolate in a facolitic glaucoma. In your case, you will not give any cycloplegic.
Ma'am, to relieve the ciliary spasm, we give cycloplegic, ma'am.
Which
So
cycloplegic?
post-operative,
Which cycloplegic would you like to give?
ma'am, we can give cyclopentolate or hometropine.
Cyclopentolate or homatropine?
Yes, ma'am.
Why not atropine?
Ma'am, atropine we can give, but it comes as ointment form, and it will the
Comes in
effect
drop
will
form.
be staying still till
It
14 days.
comes in drop
It's
form
going to-
also. It comes
Yes,
in drop form also.
yes, ma'am. But the effect will stay after the discontinuation of the drug till 14
Okay.
days.
Second part is which topical anti-glaucoma drug you are giving in this case?
Ma'am, we gave brimonidine and brinzolamide, ma'am.
Somewhere you have mentioned beta blocker, Timolate, I think.
No,
in your
ma'am.
presentation.
Brimonidine and brinzolamide, ma'am.
Okay. Okay. Then that's okay. Thank you.
Thank you, ma'am. And thank you, Soumyasri. Our last presenter is Dr. Lipsa Mohapatra. Lipsa, your screen is visible.
Yes, ma'am.
Yeah, you can start.
Please make it full screen. Yes, you can start now. It is full screen.
Screen is not visible to me.
Sorry?
My screen is not visible to me.
Okay, go back, like exit the slideshow and start again. Or you can reshare also. Close it and reshare once again.
Yes, ma'am. Ma'am, now is the screen is visible?
Yes, your screen is visible.
Good evening, everyone. Today I'm going to present a case of glaucomatous optic atrophy. A 48-year-old Hindu male came to our ophthalmology OPD with chief complaint of diminution of vision since 5 months, which was gradual and progressive in nature, associated with intermittent pain, watering. The patient was using either dorzolamide, either brimonidine plus stimulant since 5 months. There is no significant past history. On personal history, the patient was addicted to tobacco, alcohol occasionally. On physical examination, patient is conscious, oriented to time, place, and person. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. The pulse rate was 74 beats per minute. Blood pressure was 110/70 mm mercury, and other systemic examination were within normal limit. On antecedent examination of the right eye, the lid and index was normal, conjunctiva was normal. Cornea, there is the microcystic epithelial edema. Antechamber was shallow with Bohner grading grade 2. Pupil is circular, medialated, and non-reacting to light. Lens is cataractous with NS nucleus grade 2. The visual acuity of right eye was PL negative.
and of left eye was 6/9. Intraocular pressure of the right eye was 42 mm mercury, and of left eye was 14 mm mercury. This is the slit lamp picture of the right eye, showing the shallow anterior chamber. This is the fundoscopy picture of the right eye, showing the normal shape size of normal shape sized optic disc with CD ratio 0.8:1. With there is a fundal reflex is present, and the blood vessels and periphery within normal limit. And in the left eye, the fundoscopy, there is the normal size shape of the optic disc with CD ratio 0.5, and other peripheral and blood vessels within normal limit. This is the OCT RNFL picture of the right eye, showing thinning of the superior temporal and infratemporal quadrant, and of the left eye with thinning of the neuroretinal rim of the temporal and inferior temporal quadrant. Then gonioscopy was done. On gonioscopy of the right eye, in the superior nasal and inferior quadrant up to trabecular meso was seen, and temporally up to scabious line was seen. And in left eye, on gonioscopy, in superior and inferior quadrant up to scleral spur was seen, and in temporal nasal quadrant up to ciliary body band was seen. The Humphrey visual field perimetry 24-2 was done, but right eye could not be done because its vision is VL negative, and of left eye it is normal. So my summary was a 48-year-old Hindu male who came with gradual painless progressive loss of vision right eye with shallow anterior chamber on gonioscopy narrow angle in all 4 quadrants with pupil circular non-reacting to light on fundoscopy pale disc with CD ratio 0.8 and OCT NFL superior, inferior and temporal neuroretinal rim thinning with intraocular pressure 42 mm mercury with PL absent. So my provisional diagnosis was glaucomatous optic atrophy with nuclear sclerosis grade 2 of right eye. The patient was managed with injection mannitol, injection pantoprazole, hydromoxifloxacin, hydroprednisolone acetate, hydrotimolol, hydrobrimonidine, hydrobrinzolamide with hydrop NaCl and tablet vitamin C and tablet serosopeptidase. So my conclusion is early diagnosis and lifelong management are crucial to prevent significant visual loss in glaucoma. Early detection and treatment with medications or laser therapy or surgery can slow the progression but cannot restore the lost vision. The glaucomatous optic atrophy results from progressive damage to the optic nerve leading to the permanent vision loss if untreated. While damage is irreversible, treatment focuses on the lowering IOP using medications, and laser therapy or surgery is required to prevent the further loss. Thank you.
Thank you, Lipsa. I would request Amika ma'am to ask questions to Lipsa.
So, which gonioscope did you use? I just want to ask for the gonioscopy.
Goldman's
gonioscope. So you have a case of unilateral angle closure, right?
Yes,
According to you, the left eye angle was open. That was open after indentation. I mean, this was a Goldman, right?
Yes, non-indented.
Okay, so you did not do the indentation. So you have a case of secondary angle closure, I mean unilateral angle closure, right, in this eye. So what could be the causes which you would have ruled out?
Ma'am, it may be before the patient was not diagnosed with glaucoma, just 5 months before he was diagnosed with glaucoma and started the medications. So maybe long-term glaucomatous disc damage.
Which type of glaucoma is it?
Angle closure.
How would you categorize this glaucoma? Angle closure. So once you gave the mannitol, did the cornea clear up?
Yes, ma'am. Actually, we have given mannitol for 3 days, but after 3 days, the patient was lost to follow.
Okay, and you
And
rechecked the
after 3 days, the
vision
patient's
once
IOP
it
was
cleared up?
26. Yes, sorry, ma'am.
Did you recheck the vision once the cornea cleared up?
Ma'am, vision was PL negative.
Negative, okay. So would you consider doing the other eye gonioscopy with another lens in view of one eye angle closure?
Ma'am, other eye gonioscopy was already done.
With a different type of gonioscope, would you think that would be give you more information?
Ma'am, indentation gonioscope.
Thank you, ma'am, and thank you, Lipsa. I would request our three judges to complete their score sheet and share with our CSC ma'am, Sarvista ma'am, so that we can announce the winner now also. And Dr. Naresh Desai, Naresh bhai, are you there? Naresh bhai?
Yeah, I can hear you.
Yeah, bhai. My question is, this patient, PL negative patient,
Okay.
how aggressive you will be to manage this sort of patient, like PL negative patient, high pressure?
See, PL negative patient, we all know once the patient is get PL negative means there is no hope of getting the vision from there. Only thing, if the patient is symptomatic, if he is having pain, redness or anything else, patient cannot tolerate the thing, pain or headache, then we can intervene the patient. So nowadays lot of things, the lasers have come, so we can do the diode laser also, diode CPC. By that we can reduce the IOP and can help the patient. Otherwise, I don't think any need of intervention in those cases.
So if the
PL
patient
negative
is,
cases, yeah, in particular.
yeah. And laser will be your choice of modality rather than taking the patient for
Yeah,
surgery.
definitely we were doing the cyclocryopexy.
Okay.
That is the
That
but
was
that
it
was very
once
painful. Yeah, that
a
was very
painful
painful,
process.
and many times the eye become thysical. So that
Yeah.
was again causing one cosmetic issue. So at
Yes.
least on diode laser CPC, cyclophotocoagulation, the cryopexy, it will not allow the eye to get thysical.
Okay. Thank you, bhai.
And less painful also comparison to cryopexis.
Okay.
Pranamita, actually, I want to tell one thing for the PG students.
Yes, ma'am.
Everyone is telling PL negative. It might be malingering, not this case, but why not patient denies PL? Whatever patient tells that we have to write or that we have to tell. Patient denying PL. So why PL negative? Okay. So this information is for the postgraduate students. Actually, instead of PL negative, because malingering cases may be there.
Yeah.
And
And one
another
should recheck the PL also after bringing the pressure down. You cannot declare the patient PL negative if the pressure is so much high. So you have to bring down the pressure to lower level so that cornea is clear and that thing. And then again, you have to check the PL to know the vision potential of the patient.
Yeah, see, PL is a subjective testing.
Yeah.
So the patient say he can see or not. The one thing, the objective is we can know by the pupillary reflex. Okay, if the
Yes.
pupil is reacting, then definitely patient may have vision. So patient might be malingering or something, you can say. So PL is definitely subjective. We cannot trust on that. But before dilatation, we must check the pupil. If the pupil is reacting, then definitely the eye may not be PL negative.
Yeah, exactly.
That is.
And regarding the first case, that eye syndrome, do you take the patient for ACP or you plan TRAB also in those patients? Any comment from anyone?
Sorry, I have missed the first case.
First case.
So
Okay.
yeah, in those cases, trabeculectomy is the best choice, and if trabeculectomy fails, then definitely tubes are the best options. When we have tried many cases, but in long run, most of the eyes that become PL negative, but we can preserve the vision for long time. Okay. So IC syndrome. So
Thank you. Yes,
best is the
Emmanuel.
surgical treatment.
Yeah,
Either
so
we do
the
the trabeculectomy or tubes.
Yeah, I
Yeah.
agree with the trap because even the endothelial count was less.
Yes.
And plus, you're putting a tube in there. You're also giving
Yeah.
dozolamide, I think. So that's also a challenge. With trab, I've seen if we do the trab, they may need needling, and but post needling also, and maybe with one medication later on, it's for a long
They do.
time. You can maintain these patients. You always have that option of a tube, but I think I
Going back.
would keep it last
Exactly.
and in advanced cupping, you would go for a valve device, I think. Well,
Yes.
because you want immediate lowering of the pumping.
Okay. Right, ma'am. That's thing. And regarding drug-induced glaucoma, we have angle closure glaucoma. In your expression, have you seen pregabalin causing acute angle closure?
I didn't hear your question.
No, the patient, I think two systems are on for somebody. So
Your
much echo
voice
is
is
there.
echoing, yeah.
Yeah.
I think you have two devices on, maybe.
Mine is closed only. I think somebody else. Yeah, it's okay now. No, still. I think
Rita ma'am.
Rita ma'am has, yeah, no. Ma'am, you have to close one device. Rita ma'am.
Just a minute.
Yes, ma'am.
I have mailed the score sheet.
Thank you, ma'am.
You got?
Ma'am, yeah. No, you have mailed me or our.
No, I mailed ma'am.
I have got it. Yeah, I have got
okay.
it. Thanks, ma'am.
Okay, great. Okay.
I'm waiting for Dr. Devashish and Dr. Rita, ma'am.
Okay. So I was asking, ma'am, regarding drug-induced angle closure glaucoma, the patient was on pregabalin also. In your experience, have you seen patient developing like acute angle closure with pregabalin?
No, I have not encountered.
Okay.
I have not encountered.
And how common is acetazolamide causing acute angle closure, like that case, no, second drug-induced case? And that was a mixed.
I've seen acetazolamide cases, but topiramate-induced cases are much more.
Yeah.
In my clinical practice.
Yes, ma'am. Hello? Yeah, Devasi sir, are you there?
Yes,
I think
yes.
Rita ma'am, yes. What is your approach to a faculty glaucoma patients? Like your management part, how do you approach that patient?
This is for me.
Yeah, anybody?
So if it is a faculty glaucoma and the history is say more than a few weeks more, I would ideally like to go for a combined cataract and glaucoma surgery. So sometimes you're not sure about the zonular status, so you can even try a SICS with trabeculectomy. If phaco-trabeculectomy is possible, then it's fine, or else you can go for an SICS with trabeculectomy. Because most of these cases will still have a high IOP, because a phacolytic glaucoma will have a permanent damage to the trabecular meshwork once the disease is a few weeks duration or more.
Yeah. And what is your this cut up any duration is there? After that you take for some studies, say 4 weeks or this thing, do you go by that?
Yeah, I think more than 2 weeks is a valid indication for a surgery.
Amaki ma'am, what is your approach there?
Yeah, I think a longer duration of the symptoms, you would want to combine it with trabeculectomy. Some studies say 2 weeks, some studies say 4 weeks, but usually we go by like at least 4 weeks, maybe. But also depends on the presenting IOP.
Yes, exactly. And I would request you to tell our BGs how to they can denote in the gonioscopy. You see, ma'am, they're putting 2 lines and writing this thing. So, but how to properly document gonioscopy, like you can tell them so that they will learn something.
Sure, we tell a simple way to do that.
Yes, ma'am. You can tell them how they can. Rita,
So
ma'am.
basically, you need to draw the structures which you see. So the last scene structure. So suppose you're seeing up to the PTM, you write the PTM. So you can see up to the ciliary body band, you can write the ciliary band in that quadrant.
Yeah.
So it's a very simplest depiction of whatever the last structure you can see.
And they have to comment on pigmentation also and presence
Yes.
of pus also.
So
That thing,
NBI, pus, pigmentation,
yeah,
Gardner Clem's canal, all these are the comments which it can be
yeah.
put.
So for postgraduates, when you are writing gonioscopy, you have to mention all those things. Even if you are able to appreciate iris configuration also, that also you should denote there. But TM pigmentation and pus, they are valuable. You should write while documenting your gonioscopy. And I will ask Jay, Dr. Jay, are you there? Still there? Dr. Jay?
Yes, madam, I am here.
Yeah, to describe, how will you describe your optic disc? Under
Optic
what
disc,
heading you will describe a optic disc when you are describing your optic disc?
madam, size, shape, color, vertical cup disc ratio, neuroretinal rim, blood vessels, and if there is any associated abnormalities like hemorrhage, that should also be mentioned.
Rita ma'am, you want to add something to that? Rita ma'am, you are muted.
Already,
Yeah.
am I audible now?
Yes, ma'am,
Yes,
you are
madam.
Optic
audible.
disc, yeah. Optic disc size, shape, color, cup disc ratio, then neuroretinal rim and RNFL, and then artery and vein, macula, and rest of the retina. And nobody is mentioning about the RNFL. In the optic disc, nobody is mentioning around the RNFL and peripapillary area.
Yeah.
And another
Yes,
thing, what we
peripapillary.
saw,
Yes.
in one presentation, there was optic disc pallor, which was more than, right eye was more than left eye, and left eye it was mostly looking like secondary optic atrophy, not primary.
Okay.
So, because one sector, the disc was hyperemic in the superior sector in one presentation, but it was not glaucomatous, and it was not matching at all with the disc finding field effect. So gonioscopy also.
Oh yeah. Yes, ma'am.
Gonioscopy also, someone mentioned it was open angle. Always we tell angle is not occludable. Angle is not whether and it's gonioscopy. What I'll tell, it should be in a proper condition. The room light illumination and everything should be taken care of. Not that you will fully open your slit lamp light and you will press the gonio lens. Even if you are not comfortable with 4 mirror, do it with 2 mirror. No problem with that. But your gonioscopy condition should be proper, and you should mention it's whether the angle is occludable or not. If it's occludable, then you should tell whether it's appositional closure or it's cynical closure. If it's open, then up to what quadrant? Suppose 360-degree up to scleral spur is visible. Then what is the pigmentation of the trabecular meshwork? It is important. Any other abnormal structures you are seeing, suppose in a blunt trauma, you are seeing angle recession, then up to what quadrant? It is important. It's 90-degree, then your follow-up depends on that. If it's 180-degree or 270-degree, your follow-up will be like that. Or you'll anticipate, if it's 270-degree, I'm anticipating a glaucoma might occur soon or like that. So every point is important. And another thing I like to tell, so many people are using timolol, and when it's a very simple thing, when you're using timolol, always see whether the patient is asthmatic or not, or you should ask the patient for a simple punctal occlusion. Whenever you're using timolol, ask the patient to do a punctal occlusion always. It's a habit.
Thank you, ma'am. Like they are the basic thing everybody should take into account while managing such patient. Simanta Behra, sir. Hello, sir. Do you have any questions?
Yeah. One simple thing for the postgraduates, what I have noticed in their presentation. So 1-2 angle closure glaucoma cases has been presented. Presentation were very good, but I have noticed that the chronology of the presentation, that is the symptom sign, that was actually not properly maintained. Like we were discussing about the gonioscopy, but in one cases the presenter first she mentioned the gonioscopy finding, then she did the tonometry. Actually, that is not the proper way of examination of the patient. So whenever we are doing any contact procedure, that has to be followed by the gonioscope. That has to be, yeah, that has to be done after the tonometry, because once you have done the contact procedure, then the tonometry reading will be less. So after gonioscopy, usually the tonometry is not recommended and not supposed to do, but the presenters are presenting like that. So just I remind the postgraduate, so always do the tonometry first, then the gonioscopy.
Thank you, Ari. Shivanta sir, you have any questions for anybody?
Hello.
Oh, sir, you are visible. Sorry, you are audible.
Actually, in my young days, while doing gonioscopy, I was very much interested on gonioscopy. There is a gonioscopy chart. We are having a gonioscopy chart, and you have to chart it from the ciliary body to the soldier line, all these things up to scale up. And in each quadrant, it has to be a diagram properly. That is a gonioscopy chart. I don't know whether you are adopting it nowadays, but in our time it was there. We are following that chart, like your indirect ophthalmoscopy chart. There is a gonioscopy chart too also. So we are doing according to that, and we are seeing all the quadrants. That helps us to know what is there in each quadrant.
Yeah. Nowadays, sir, simply we follow, like ma'am said, like 4 quadrant, and we'll write what we can see in that thing. That will be the
No, we have
simplest
to have there was a chart for that
chart.
only.
Yeah. Yes, sir. Different grading systems are there. Yeah. Samir sir, any comment from you? Samir sir, are you there? Ma'am, are you ready with the tabulation part? Okay, yes, ma'am. Yeah.
Sent to Sarmista. Sarmista, I have already sent it.
Yeah, she has got that, ma'am, I think. Yes, Devasi sir, your experience with this webinar?
Excellent. I enjoyed all the presentations. They tried their best, and a lot of varied presentations, drug-induced glaucomas, phacolytic glaucomas, IC syndrome management. Nice presentations. I enjoyed.
Their first year PGs also are there, sir. One consultant is there and rest are PG and one fellow is there.
Yes.
Yeah.
So at their level, it is really good. They have attempted to present glaucoma cases and with all the findings and tried to understand the cases. That is really common.
Exactly. Amika ma'am, any words from you?
Yeah, first of all, thank you for having me here. I really enjoyed seeing all the case presentations, and of course, it's a they'll grow from here and they'll learn, and it's a good platform you have provided them. So it's really nice, and I got to see the ocular emergencies, which we don't see that often here, but the the
Thank you.
real world scenario.
Thank you, ma'am.
Antibiotic. Hello.
Yes, ma'am.
Yeah, I'm here with the.
Anamita.
Yes, sir.
Anamita.
Yes, sir.
Everyone was really interesting. And one point I'd like to add is that the clinical understanding in whole are nice.
Hello.
Okay, actually, Dr. Samir is in his hometown where the connection is a little low. So I think can I go ahead with the results?
Yes, ma'am.
Yes. The winner is today's winner is Dr. Nivedita Sahu. So a big applause to you, Dr. Nivedita.
Congratulations.
Congratulations.
And
She's not there, I think.
the runners up, the second position goes to Dr. Pragyananda.
Okay.
Dr. Pragyananda. And congrats. And the third position goes to Dr. Lipsa Sahu. Actually, my point is everyone is a winner, all of us too. So this is just a small competition just to increase the enthusiasm of all the residents and all everyone who participated. Thank you all. Can I go ahead with the vote of thanks? Sir, Srimanta sir.
Kuandu. Yes.
Vote of thanks kaiki saridava sir.
No, I want to speak something about your scientific activities. Really, these are very nice. I am really in this age, I am enjoying it. I wish all the members of our OSS and those who are come from AIOS must be enjoying. You are putting nice contents of the webinars each time. It's a very good effort. Thank you.
Thank you so much, sir. Sir, let me go ahead with the vote of thanks. A special note of thanks to our judges who have taken their time out and to judge, and especially all the three of them. We have got so much to learn from you all, ma'am. I felt like appearing for an examination, especially Rita, ma'am. You would have been a very tough professor. The questions were, and both MK ma'am and also Devashish were very good. Thank you so much for being with us. Yes, Samir, Dr. Samir, he's saying something. And thank you all the participants who have really come forward to present this case.
During that time even, I trained from Rita ma'am regarding SISs and glaucoma.
Thank you so much.
My time of SIS training at the
That time I was tough.
You are not tough, ma'am. You are very good. And thank you all the participants and all those who have joined us virtually, and all the patients, of course, and finally Entod for giving us the platform. And thank you all our chair and co-chairs, Srimanta sir, who is always with us, a strong pillar for us, Dr. Naresh and Dr. Samir, our general secretary, all of us. Thank you so much.
Thank
Good night.
Good night. Thank you, ma'am. Good night, ma'am. Good night, everyone.
Thank you.
Thank you, all my colleagues.
And thank you, our moderator.
everybody.
Sorry, I'm sorry. Thank you, our moderator, Dr. Pranamita Pujari, who did a wonderful job today.
Yes, wonderful.
Wonderful job.
Always.
Thank you, Pranamita. Good night,
Bye,
everybody.
ma'am.
Thank you.
Good night.
Good night.
And congrats all the participants.
Thank you, ma'am.
Thank you.